Alrighty, let's move us on to what I like to call, as soon as it shows up, the hierarchy of lactation. So similar to Maslow's hierarchy of needs, I find that there's also a hierarchy in lactation. And that's because we need to look at the overall of infant feeding. So on the first, which we're going to go from down up instead of up down, we're going to go from down up. And the first one I have labeled is maternal wellness. If a parent is not healthy from within, and this could mean anything from if the person has polycystic ovarian syndrome, has high blood pressure, has type 1 or type 2 diabetes, or has symptoms of depression or anxiety. These could be some roadblocks when it comes to having sufficient human milk. And that is because in each of these situations, hormones are involved. And specifically with polycystic ovarian syndrome, there's too much thyroid in comparison to estrogen, which now kind of like interrupts the prolactin and the oxytocin. And with anxiety and depression, there is minimal release of oxytocin, which also interrupts the making of human milk. So oxytocin, typically we know this, especially if you've done doula work or have doula training, the love hormone, and is present in a series of or in different types of settings, such as lovemaking, laughing, being happy, but it also is the main source of getting this milk out of us, right? Prolactin kind of fills up the glands where we make milk, and then oxytocin kind of squeezes it out of us. And you'll see a really cool video that I have for you guys where you're going to learn more in depth of what's going in from within. But for this, the maternal wellness is so important because in those hormonal situations and in the mental health aspect, and even with social and emotional health, let's say the parent is not in a safe environment where they can latch freely, maybe have an overpowering mother or mother-in-law or father-in-law. I have had some cases as such where maybe the person is obligated to breastfeed or being ridiculed for breastfeeding. Maybe they don't have a supportive partner. And I've seen also some cases where they don't have supportive older children where they just don't like it. So if the parent doesn't feel safe in what they're doing, they don't trust their bodies, and they have mixed emotions about what's happening, then this creates kind of a whirlwind of effects mentally and emotionally in the person, which then interrupts the making of human milk. Then we also have infant comfort. So with the maternal wellness is also the parent, right, feeling comfortable, the breast, you don't have a bloody nipple hanging out and only hanging on by a thread. Parents has a comfortable location for them to breastfeed, but the maternal wellness and the mother's comfort or the parent's comfort comes first, then the infant's comfort. So when I talk about infant's comfort is, let me see if I find my baby, is that sometimes I've seen parents that they will latch their baby in a way where it's like, oh my God, is that child okay? Right? We don't want child to be their body facing upward and then their head kind of turns to the side, because who can eat with their head turned, right? It doesn't allow for that esophagus to be straight and for them to be able to suck and eat. So if the baby's not comfortable, maybe because the way the parent is holding them, or maybe the parent has babies in the back of their head, which this would cause a reflex to jerk back, or maybe the person is maybe tense because of the way they're feeling, or because the way they're sitting. If they latched in a way where they kind of hunched over, it creates so much tension in our shoulder that sometimes that can allow the parent unknowingly to hold their child in a tense way, and children feel that, like, right, external partners, we know when our partners are a little tense because of the way maybe they speak or the way they hold us. So we want the child to be comfortable. We want the child to be placed in a position where it's conducive to feeding, right? This whole neck to the side while the body's facing upward, that is not conducive to a feeding. Conducive to a feeding would be belly to belly. The baby is facing the mother completely, and then the mother is able to latch the baby on. And then we look at latching. So first, when we triaging a lactating parent, we want to make sure that the parent first is doing well mentally, socially, healthy, or at least health wise. And then that the infant in the act of latching, the baby's comfortable, right? We want the baby to be able to approach the breast. We don't want parents hovering over. And then lastly, we'll look at oral functions. So when we're discussing with a postpartum parent or a parent that is getting ready to feed, we just want them, we just want to coach them in a way that allows them to expand their thinking and their understanding of what it is to feed a child, right? We don't latch for 5, 10 minutes and that's it. So why do we expect ourselves to be in these awkward positions when nursing, when we really can tolerate that kind of tension in our body? So we always want to encourage the parent to sit in their favorite place, have extra pillows, have extra blankets, anything that they might need, and remind them that it's not going to look like this all the time. It's just the first few weeks where they're kind of understanding each other. Mom and baby are both learning how to feed, or well, mom how to feed the babies, how to drink. Even if they had other children, right? Even if they're seasoned, it's one of those things that we just forget because it's so early in our journey that fast forward when the child is like 2, 3, or as early as 12 months, we forget these small details, right? So we encourage the parent to first get comfy. Then we encourage the parent to now bring the baby to them. So let's say I'm nice and comfortable. Now I'm going to bring baby to me and I'm going to use any other things external that can help me sustain the baby's weight. Again, this could be a pillow, this could be a blanket, this could be something in my back, anything that just can help the parent hold the baby for the length of the feeding. Then we're going to look at the latching. How are you approaching the latch? Are you allowing the baby to use his reflexes when it approaches the latch? Are you bringing the baby over to you? Or are you trying to, like I used to say, are you trying to chase the baby's mouth, which that will only lead to putting the nipple where it is going to hurt? But when we allow the baby to approach the breast and then we latch them, or we bring them over to us when they indicate that they're ready, and that will mean opening their mouth wide, now we can focus on the feeding. When things starts to go wrong, we go right back to the hierarchy of latching, of lactation. We start to look at what's going on in maternal health. How is the parent approaching the latch? How is the latch going? And then lastly, oral ties. What is going on inside the baby's mouth? Because if the parent says, hey, I am producing, I breastfeed the baby as much as I can, or when I latch, it just really hurts and I try to bear it through, or I'm latching but it hurts, and then I'm resorted to pumping and I'm pumping 2, 3, 4 ounces, or if not more, then we know that the parent is not the issue. Then what's next on the step? The baby. If the latch looks good, but the parent reports a ton of pain, then that let us know that something else is going on. It's not the latch, it's not maternal health, it's not the infant's comfort. Mom is doing everything correctly, per se. So then we start looking inside the baby's mouth. Now, again, remember for the disclosure, we don't go inside the baby's mouth. Well, you guys don't go inside the baby's mouth because it's first, you might not know what you're looking at. And sometimes oral ties can be a little confusing, even for me at times. Although I can dig in, I cannot diagnose. So all I do is dig in just to assess what am I looking at, and then I refer out. But sometimes, again, tongue ties can be a little tricky, and I will talk a lot about this in the next section. But the mucous membrane that is underneath the tongue sometimes can run far deeper than what we can see. So the obvious ties are the ones that are in the very tip of the tongue or a little after the tip of the tongue, which when the baby elevates, you can kind of like, you don't even need to touch it, you just look at the baby crying, boom, you can see that it's right there. But there's more to the story because there could be other type of ties. Cheek ties. Inside the cheek, there could be ties. Sometimes in the back of the cheek, those are a little rare, but you still see them. Sometimes it can be that it's not a tie. Sometimes we can see that there is a lack of elevation in the tongue when the babies cry. The tongue kind of stays a little down, but it could be other things. It could be birth trauma. Baby that was born breech tends to have a lot of tension in its neck, in its shoulder, in the back of the in the spinal cord. So sometimes they don't get to open up wide enough and achieve a good latch, or sometimes they're chompy when they latch. You might hear a parent say, "Hey, when I latch, it's like chewing or it's like munching on the breast." I call those piranhas. I'm like, are there piranhas where they just latch and then they go really fast? A lot of that is a lot of tension in the jaw and in the face. Again, we see that with babies that are born breech. We see that babies that were taking long to descend. I had a parent where she spent 3 hours pushing because the baby was failure to descend, and then it resulted in a C-section. So now we have a child that naturally, as the physical body was trying to push this baby down, he was stuck in that canal. So now we have a lot of tension in the neck. So that just doesn't allow for the baby to do a sort of range of motion with their mechanics of the jaw, which then can start causing symptoms in the mom that can really look similar to a tongue tied, and then it's not, right? So we much rather refer out. We much rather call in another professional that knows, because sometimes we can be very helpful and say to a parent, well, I think sometimes I hear go to a pediatric dentist, or my goodness, go to ENT. And if the person is not specialized specifically in oral ties and have a history in working with parents in a way that involves the whole entire dyad, right? Sorry, that involves the dyad or the whole entire unit, dad, aunt, whoever is involved with this child, because I see it more as a village. So the ideal pattern of helping parents, this spectrum of the hierarchy of lactation, is bringing other professionals in, but also bringing the family in. That's because they're going to be the coach, they're going to be the reminder, they're going to be the support system of this family. So, just to kind of wrap it up with the ENT or the pediatric dentist or any other provider that is going to further assess an oral time, we want to pair them also with a lactation consultant. And this is because if there is an oral tie, the best approach to that would be to have the parent practice some exercises before the release. This is to allow a little bit more of a stretch of that membrane and allow the dentist or the ENT to get a better view of what's happening. So if we can have the child open up a little better with some massages. Oh, with that also, some babies are born with really fat cheeks, and sometimes we look at them and they're like, oh my God, look at the chubby cheeks. Those chubby cheeks can bring problems. And it might not be an oral time, might be that baby got some really muscular cheeks. That can cause some bad latches as well. So the lactation consultant can work on some exercises before and then after. We also help parents get comfortable with going inside the baby's mouth. Not many parents are comfortable sticking their finger in a baby's mouth, let alone after a procedure where the baby is crying bloody murder and the parents are now flabbergasted because they are still in postpartum. Um, they don't want to hurt their baby. Sometimes, if they're not or they weren't familiar with what exercise to practice, giving them a sheet, which some providers will do, or they would do the exercises right then and there, have the parents record. Just not the same when you got some time to practice, to become familiar, to then build a system of what we will do post release. We always recommend parents to set a time aside where the whole entire day of that procedure day to not do anything and not do anything the next day. And then hopefully the provider can see them on day 2 or day 3. But that day and the day afterwards, I tell parents, block off everything on your calendar. Put your phone on silent. Order DoorDash if you need to, or have somebody bring you over food. But this is going to be a time where you're just going to be practicing those exercises, because when you see the womb, it's more like a triangular shape, right? And then some of those exercises going to be to push on their tongue upward to allow for that healing to occur this way. So the human body naturally heals like this, kind of like squunched up together. So the idea of after a tongue release, we want to keep that open diamond. That diamond kind of opened and then healed in a way that it just unites. Now you have a tongue that can continue to have a long stretch, opposed to if it would have healed scrunched up. We just took this tongue from nice and released to right back where it was. So these type of exercises really help parents to do the therapy themselves, but we'll talk in another section what entails to a release, and also we'll tell you a little bit more about what type of ties there are there. But for now, I want you to take this of hierarchy of lactation and put it into your practice. Whenever you're visiting a client, a patient, and I'm telling you, hey, I'm having difficulties latching. I'm really trying to get this going. My nipples are bloody, irritable, sore, and you want to just offer that guidance of, well, let's see, get curious. Let's see how you latch. Show me how you're latching, and then just be observant. Be observant to their approach. Sorry, be observant first to how are they sitting. Sorry, how are they sitting? Um, how are they comfortable? Do they have what they need at close range opposed to having to reach over or call somebody over? How are they positioned? Then I want you to look at infant's comfort. How is her, when she approaches the baby to her, how is the baby positioned? Is the baby conducive to the feeding, meaning it's belly to belly? Is the baby able to use his full range of motion? You know, parents love to have these poor gloves on the babies, and we don't want any gloves. At least, I understand they scratch their face, but at least for the feeding, no gloves. Because again, remember the mammals, remember the kittens, right? We as mammals, we use our hands to eat. Think of some cultures where they don't use utensils, they use their hands. I know I was raised in that way where my mother would feed us when we were children by hand. And that's how she was taught. And that's how I also fed my children when we were introducing solids. We used our hands, and that's just cultural. Or at least in my family, it was just a practice. So we want those mittens nice and free. So when baby's approaching the latch, are the hands free? Is the baby nicely positioned, or does it look like the baby's going to fall off the mom's lap? Or is the mom holding the baby bare with nothing to help her sustain the weight? And is those poor feet are dangling, which give them a sensation that they're falling? Is mom latching more in a position where the baby is more laying down and the baby's trying to approach the breast upward, which again could give a weird sensation to the child? And then the latching. When the baby approaches the latch, do you see a mouth that is nice and wide? Or do you see nice and wide? Oh, I like my mouth. So nice and wide. Or do you see a baby that is kind of pinching and you can kind of see both lips are in close proximity? Because the idea is where the lip and the top lip and the bottom lip are at a pretty much like a 90 degree angle, where you want them specifically, okay, one is up and one is down. You want to see a good space between that. And then lastly, you want to have her kind of describe what she's feeling. Does she feel any pinching? Does she feel um, any chomping, right? And with all of that, you're going to grab all that data and you're going to refer on out. You can refer to lactation consultant or to the pediatrician, depending on the severity. But for your anticipatory guidance, then what you can coach the mom and say, hey, do you have an extra blanket? You could roll the extra blanket and put it underneath the baby so the mom can now just focus on latching the baby instead of holding the baby and sustaining the baby's weight and trying to have this wiggly child move all the way around. You might ask the parent to kind of bring the baby a little closer. You start to notice that the baby's neck is a little off to the side. Hey, how about we put the baby kind of tummy to tummy so they have a better approach? So you can make all these recommendations to help the parent in that motion. And if they're already sore, it might be that she does get a good latch with your support. But don't be surprised if the parent says, it feels better, but it still hurts. Once soreness is present, then there will still be some sort of pain because it's already sore, was present. So then with fixing the latch, then it comes with treating the nipple. Now, we no longer recommend using lanolin to treat nipples because we found that that causes and breeds bacteria. We use natural substance such as coconut oil, preferably, or coconut oil if that's all they have, or if they want to purchase any organic balm that have organic ingredients, then they're most welcome to do that. Earth Mama is a good kind of choice. It is a little pricey. And then for our community, I like to provide suggestions that they might already have in their kitchen. They might already have coconut oil. They might already have olive oil. So, because the idea is that we want to keep dehydrating as the body naturally heals. Before I forget, another great thing is putting breast milk first, doing a light hand expression, and then putting some of that breast milk first, letting it dry, then putting a thin layer of coconut oil, also letting it dry. And if they need to cover themselves up, then awesome. Sometimes I ask them, hey, be topless, right? Use a very big shirt and just let your nips hang out as you're allowing them to kind of get back to where they were. But treatment after latching is very important because once you're already sore and we fix the latch, we expect some soreness until just the skin starts to get better. So make sure you're using your workbook and leave your comments or questions in the bottom. See you on the next section.